Um, this has been a very exciting past few years in our field, and I'll explain why. I came to the University of Chicago in 1993, so I've been in Chicago, originally from New York, sorry about that, for over 30 years. And back when I came here, guess what? There really weren't very many exciting things. Most of the exciting breakthroughs we had were not really that exciting, but we pretended they were. But the exciting breakthroughs we had were so many breakthroughs recently. I'm going to give you an update about this. And then Dr. Dalal, Sushila, she's going to come up and give you a little different perspective on some other important issues in inflammatory bowel disease. So inflammatory bowel disease is generally considered ulcerative colitis and Crohn's disease. You may have heard those terms many times, especially if you have a TV. But sometimes we're not quite sure. And the reason why we're not sure is because the body doesn't read the textbooks, okay? So if we say this side is ulcerative colitis and this side is Crohn's disease, in reality, there's probably 5 or 6 variations, and the body may go from one state to the other based upon maybe what's going on with the environment, the diet, maybe the medicines we do, things like that too. So it's okay if your diagnosis changes. It doesn't mean someone got it wrong. It just means, like I said, your body is in a situation where it can change things. Now, let's presume that most people, if not many people in this room, have guts inside of them. And hopefully you won't have this experience from the food that you were given here or the drink, but at some point you'll probably have an inflammation, perhaps from food poisoning or from travel or whatever it may be. And your bowels, you can see in the middle, that shows your colon, gets inflamed, right? That's why it's red. So normally what happens is that it gets inflamed, your immune system acts up and takes care of whatever the problem is, and then the immune system turns back to the resting state, almost like the military going back to the camps, the base camps. You know, they took care of the enemy, and now they're just waiting there in case another enemy appears, and that's the bottom right. That's normal. But in patients with Crohn's and colitis, for some reason, the immune system doesn't turn off. It stays out, and it still keeps on fighting even after the enemy's gone. And that can cause chronic problems with Crohn's and colitis. So there's many different studies looking at, this is the most complex slide you're going to see, many different areas that of their cells and the linings of the blood vessels and the lining of the bowel wall, where we have known for many years and learning always about different ways the immune system, your white blood cells, are trying to protect you and interact with each other. So it's almost like the game of Pac-Man. Who's ever played Pac-Man or Mrs. Pac-Man? I didn't really play Mrs. Pac-Man. Yeah, I did. I know. Okay, truth be told, I like the little bow she had. So the point is that in Pac-Man, your little character is eating the little bacteria. Your white blood cells eat actually bacteria. And the way that they bring in more Pac-Man, more white blood cells, is they release chemicals, and the chemicals in your body bring in more and more white blood cells, and you get a big immune response, right? You ever have a really bad sore throat, or your kid does? You look in the back of the throat. What are you looking for? You're looking for white spots, right? White spots on the tonsils. Well, white blood cells. That's why they're white. Okay, that's why pus is white. So essentially, the white blood cells rev up like for an infection, but they don't turn off. So as a result, many of the medicines we use are geared towards turning the immune system back to normal. Doesn't block it completely, but it puts it back to a normal state of functioning. So the first advanced therapies were over 25 years ago. So over a quarter of a century ago. So where were you in 1998? Well, in 1998, the New York Yankees won the World Series. Denver Broncos won the Super Bowl. NBA championship was the Bulls. Usually people in Chicago know one right away, and they're very happy. They're very happy. Back then. Hasn't happened too much lately. Nevertheless, believe it or not, the Red Wings won the NHL. Sorry, I know Chicago and Detroit used to be big rivals until they moved Detroit to the Eastern Conference. And the big movie of that year was Titanic. So it was all very exciting things, but what really excited me and many of our people and our patients was the very first biological therapy was approved for the treatment of Crohn's disease at the time, subsequently ulcerative colitis, called infliximab, brand name is Remicade, and it really revolutionized the way things. Now, many of those things are called MAB. See the last 3, MAB, that means monoclonal antibody. So what these things are antibodies. So what does that mean? I'll show you in a minute. So that was 1998. Guess what? In the past 3 years, we've had 10 new drug launches for Crohn's and colitis, 10. And once biologic goes off of patent, there's biosimilars, kind of like generics. Biosimilars, we had 9 new biologics. So Dr. Dalal very astutely told me that I now have 19 things that have happened in the past 3 years. And I said, well, just wait till January, because in 2025, we're going to have 3 more biosimilars for ucikitamab. So all of a sudden, you understand how difficult my life is and why I should be getting a raise from the University of Chicago. Look at all this work I've had to do. Back in 1990, I had to know 1 drug, 1. And now in the past 3 years, I've had to know 19 plus 3, 22, plus all the other ones too. So big breakthroughs with biologics. Everyone's afraid of the biologics, right? You see the commercials, all those warnings. Well, I got news for you. The biologics are far safer than anything that we've used before. They're more effective. They're safer than steroids. We still use some pills called azathioprine, Imuran, or 6-MP, 6-mercaptopurine. We still use them, but the biologics are actually safer for most people. Methotrexate also we use still, but much safer. And the key is not to wait till people get really sick, but to start them as soon as possible. Because if you do things as soon as possible, the medicines work. And if you wait until people are really, really sick, it's harder. It's harder to get things done. So it's almost like you bring your car's making a strange noise. You bring it into the person in the car repair place, and they're like, well, this is about to go. Do you let it go? No, you fix it then. So you go in, you see the doctor, they do a colonoscopy, like, this is about to go. You want to take care of it until it's too late. So it's better to use medicine earlier and get people better. Much easier. The medicines work better that way too. So I said monoclonal antibodies. So here's antibodies. They look like a Y, and they attach to the receptors on the white blood cells. So in this case, this is like the Remicade or Humira or medicines like that. They block the white blood cells. The blue thing in the middle is a white blood cell. I don't know why it's blue, but it is. And the white blood cells are sleeping. They're your military. How do you turn them on? How do you contact the military? They have to be stimulated to turn on through the receptor. With the medicine, you block the receptor. Cell can't turn on. So the white blood cell ignores the inappropriate immune response and stops attacking you. And that's how the monoclonal antibodies work. They're actually given IV or shot. They actually do look like a Y. That's why they made the cartoon. And they work very effectively. You may have heard of these. So there are many different brand names. And when they go off patent, there's biosimilars. There are Remicade, Inflectra, Inflexis, Avzola, Humira, Amgevita, many other Humira biosimilars now, Cimzia, Simponi. All of them are used for Crohn's and or ulcerative colitis. They're all in the same family. These block with the TNF alpha, tumor necrosis factor alpha, which is a very potent inflammatory protein. This is why all these years you've been seeing all those Humira commercials, because it had 10 indications from the FDA back then. It has more now. It had 10 indications, which means that you could see it for Crohn's, you could see it for colitis, you could see it for rheumatoid arthritis, you could see it for other inflammatory disease, you can see it for eye disease, you can see it for skin disease. It's like, holy cow. The linchpin for inflammation for many patients is this protein, which actually, even though it's called tumor necrosis factor, has nothing to do with tumors, doesn't cause cancer, doesn't prevent cancer, as far as you know. But that was the name that was given to it for reasons that have to do with a rabbit, but I'll tell you that story later. And brand new this year, infliximab, Remicade, is finally available as a self-injection too, after starting with the IVs. So the first medicine we had over 25 years ago now has another option this year too. Just when you thought that we milked it for every drop we've got. Nope. Terrific. Now, luckily, very few people have safety issues with these medicines. The commercials are scary. However, what the commercials don't tell you is the risk of having the bad things happen are the same whether you're on the medicine or not. Unfortunately, that's how the commercials are made. It's not the company's fault. That's how the FDA makes them report it. There are very rare risks of serious infections. Less of a problem in our country because we don't have a lot of TB and other serious infections, but sometimes we do have to be careful with it. And very, very rare risks of possibly some certain cancers. We don't really think that's true alone with these drugs, but by far the benefits outweigh the risks. So this was the first family. Okay, so where we're sitting there, and if you get into any of our programs before 2014, that's pretty much what we talk about. The program will be over, you go home. But guess what? It ain't 2014. Okay, 2014, we basically had another breakthrough, a new class, something completely different than what I told you. Isn't that exciting? And by the way, these were the teams in 2014 that won the World Series, the Super Bowl, the NBA championship, and the hockey. I didn't know the NBA won, but I knew the Patriots won because they were the Patriots and the Kings. Because remember, the Blackhawks won and then the Kings won. So if you know the years the Blackhawks won, you knew, right, exactly. So this is really cool. So this way this medicine works is, if on the top, that's your bloodstream in the gut. And then this is a white blood cell. So what happens is that when there's inflammation, your white blood cells in the bloodstream, it actually rolls along the lining of the bloodstream, and then it wedges its way into the gut. It squeezes its way through and adds to the inflammation. And the way it does it is it actually sticks. The white blood cells are very sticky. So they have what are called adhesion molecules. They adhere, right? That's where you have adhesive, right? Adhesive tape adhesion. Well, this medicine blocks the adhesion. It blocks the white blood cell from sticking. So look what the white blood cell does. It just bounces along. It doesn't get into the gut. It's in the bloodstream. It can do wonderful things for you in the bloodstream, but it doesn't get into the blood. And that's the gut. And that's the idea behind adhesion molecules. And you probably have seen commercials for this medicine, Entyvio. So Entyvio was only IV since 2014, but this year, look, now you can actually get it as a self-injection too. So again, this is the reason why my life is so exciting, even though I think I've been talking for 10 years on this drug. They change it up on me, right? Right, Archie? Archie's our pharmacist. They change it, Archie. They change it up on us, right? Okay. So now we're going to go to 2016. Another brand new class, something completely different came out. And I actually took this picture of this elephant painting. I did take this picture, not in Chicago. And this is a drug called Stelara. So I mentioned that your immune system, you have a lot of these chemicals that your body makes that causes more inflammation. Well, it turns out that two of them, the top number 12 and the bottom number 23, have a same blue part called P40. So Stelara, ustekinumab, is a monoclonal antibody, look at the Ys, against both the 12 and the 23. It blocks two parts, completely different direction than the others, but that actually is very successful in psoriasis, psoriatic arthritis, that's where Stelara started, and then Crohn's and ulcerative colitis. So that's been on the market since 2016 for us. It came out in 2012 or so for the dermatologists. And again, very few safety issues at all. There's really no known cancer risk. There's no known infection risk. And by far, the benefits outweigh the risks. So as of 2016, we had 3 different families to choose for inflammatory bowel disease, right? So 2016. By then, Dr. Dalal was already done, and she joined us, right? And you were like, well, that's it. I know everything. Poor Dr. Cohen, he had to start with none. I had to start with none, and I had to learn all this stuff. And then Dr. Dalal came. But guess what? The next year, we had another completely new medicine. In fact, everything I've shown you so far are shots and IVs. So what happens is that before we had those shots and IVs, people were taking medicines like Azicol, 12 pills a day, Pentasa, 16 pills a day, 16 pills a day. And people would say to me, can't you just give me like a shot or an IV or something? So sure, I just showed you all the medicine. So then what do people do? They complain, right? They say, oh, I want to take a pill. Well, Dr. Dalal came on and she set it down and started using pills. Now, the pills are not considered biologics because they're taken by mouth. They're called It's a novel small molecule. So any medicine you take by mouth is a small molecule. If you take a cholesterol-lowering medicine or aspirin or Tylenol, it's a small molecule. But novel small molecules mean they're new and they're expensive, right? So this actually is a little more confusing. This works instead of those antibodies preventing the cell from turning on. This works inside the cell. So if the cell was stimulated to turn on, it blocks the signal. So it's almost as if the military, the scout, actually sees the enemies coming, right? So the receptor's already been, and the scout's running back to the camp to tell the camp, hey, you better get out your guns or your tanks or your whatever you got. I don't know. What do they have these days? Lasers, right? Lasers sound very fancy, right? But the scout's message to the camp to take out your lasers never gets there, blocks it. So it blocks it inside the cell. And very effective. There's two of them on the market. One's called Xeljanz and one's called Rinvoq. You know, one of the nice things about, very few nice things about all the political commercials we had for a while was that you didn't see all the drug company commercials, but now the political commercials stopped. They're making up for lost time. So you're probably seeing commercials for these medicines as well too. They're pills, and look how happy everybody is in the commercials. They're also used for rheumatoid arthritis and psoriatic arthritis and for other inflammatory diseases. Now, I want to be very straight with you. While these are safe medicines, they probably are a little more, you have to be a little more cautious with these pills than with the IV or shot because they're more potent in certain ways. So we do have to watch for side effects a little bit more. There might be a slight increased cancer risk, but very, very, very slight in rare cases. It'll increase cholesterol. People get the shingles more. So if you have, we're trying to get all of our patients the Shingrix vaccine. If you haven't had the shingles vaccine, the Shingrix. But it's interesting because everyone thinks, oh, IVs and shots are so serious, I'd rather have a pill. Just so you know, this pill's a great pill, but it's a little more risky than the IV or shots in some patients. So it's the exact opposite people would think. A lot of people come in the office, they say, I don't want to take an IV or shot, I want to take a pill. It's like, well, actually, you probably want the IV or shot because in those, there may be a better option for them too. But wait, there's more. Right? So now we've made it initially to 2017, 2019, and then in 2021, we had another completely different medicine, also a pill, used initially for MS, multiple sclerosis. People with MS, their immune system attacks their nervous system. It actually attacks the lining of the nerves. So you ever seen like pull an electrical light switch out from the wall? You see like the red and the green and the white and the yellow. Well, that's the wires are copper, but that's plastic so that you don't short circuit. Well, we all have a coating around our nerves so we don't short circuit. And unfortunately, in MS, the white blood cells attack that coating around the nerves. And that's why they have neurologic issues too. So there's a big breakthrough in MS and now in ulcerative colitis, hopefully in Crohn's, are these pills called S1P modulators. So if you think S1P is confusing, it's really called sphingosine-1 phosphate receptor modulators. That's why we said S1P. And it actually prevents the white blood cells from attacking the bowel or the nerves in MS. It does not cause multiple sclerosis. It doesn't seem to cause anything. There's two on the market now. One's called Velsipity and one called Zeposia. Right? So again, added to your commercials. So now when you watch these commercials, you'll be like, yeah, I know about that stuff. That's right. Exactly. Right? Because you heard about the stories tonight. And again, very, very safe, but we do monitor. It can slow your heartbeat down a little bit just because it's actually not, we don't intend it to do so. It is a quote side effect. So before you start, we get an EKG to make sure your heartbeat is fine. And we have to make sure you don't have eye problems or other things too. So again, a pill, but we have to be a little more cautious with the pills than with the IVs or shots. Oh, can I sit down? Like the heck. So next, then we have another wave. So 2022 comes, and we're all dancing around. I took this picture in Chatham, Mass. These are seals off Cape Cod, right? Any of you guys ever go to Cape Cod years ago? They didn't have seals. Now they got seals. So you know what they also have? Great white sharks. You can't go in the water. There's these huge signs that have a picture of, I forgot, I should have put in the thing, they have a picture of a great white shark, and it says, don't go in the water. Basically, if you see a seal, because the sharks eat the seals, don't go in the water. And then the best part is that if you get bitten by a shark, it says call 911. Okay. So first of all, you're going to be in the water when you get bitten by the shark. Do I need to say any more? Exactly. And it's a great white shark. It's like the Jaws one. You remember the Jaws and all the guys, right? And anyway, so these, similar to Stelara, they block the other side of the protein number 23. Back in the Stelara slides a little while ago, I showed you 12 and 23 in the blue side. Well, this attacks the green side, the P19. So this is a different monoclonal antibody given IV and shot, actually. There's 3 of them on the market now, just to make my life even easier. Tremfya, you've probably seen a lot of Tremfya ads for psoriasis. Omvo, which is the first release is ulcerative colitis, not as many ads. And Skyrizi. How many of you have seen Skyrizi commercials? Exactly. How many of you have seen too many Skyrizi commercials? Exactly. I do tell you that I don't make any money on this, right? So, and these are actually very safe and effective. They happen, you first start off with IV infusions and then you move to the shots. The Skyrizi is cool because the shot, you actually don't give yourself the shot. You load it in a little machine. You stick the machine on you for 5 minutes and it gives it itself. It gives it itself. It's really cool. It's called an on-body injector. But I was told by my nurse the other day that you're not allowed to do cartwheels while you have it attached to you because it may come off. Who knew? Who asked? That's a good question. Who asked? Because who would have asked that question? Same thing. There's no known risk factors to these medicines unless you're allergic to them. While all of them say we make sure you don't have an infection when you start it and things too. There's no known risk to infection. There's no known links to cancer, anything like that too. So we also have many other therapies coming up. Some are similar to ones on the market and some are completely new. So how do we know? How do we decide which one to use? Some of you who are in this audience are my patients and Dr. Dalal's patients, and some of you may become. How do we know? Well, first of all, we say, well, I saw the commercials, right? And I saw commercials for this for psoriasis and this for rheumatoid arthritis. So maybe if you have one of these other conditions, we can treat your Crohn's or colitis and your other medical condition with one drug. Isn't that cool? 2 birds, 1 stone. Okay. Sometimes we say, well, if you do have a different medical condition, we won't use a certain medicine. It's not too many in those cases, but sometimes I mentioned one of the medicines we use for people with MS, multiple sclerosis, but if patients do have multiple sclerosis or similar diseases, we don't use other ones too. So sometimes we're like, well, we're not going to use that. Not too many cases like that. Well, guess what? Crohn's and colitis are young people, right? And we get them well and they continue having their family. So is a patient pregnant or planning to be pregnant? Just as an aside, any of the IV or shots we use in pregnancy, we don't stop it. The pill medicines that I mentioned, the advanced ones, we actually don't use in pregnancy. So for example, if you were coming in and saying, I'm planning to start a family, we would choose one that you could be on safely with pregnancy. And then we also say, well, what medicines worked before? And which ones worked but stopped working? Like, why did they stop? Was it that they never really worked before, or they were working great? And then the monoclonal antibodies, you can make your own antibodies. This is almost like a vaccine. This is why we don't like people going on and off these therapies, because you become allergic to it. Did you have any side effects? Were they side effects from the medicine? If so, maybe we'll give you a completely different one too. And did it never work? So even though it may seem very perplexing to you guys, I'm like, look at all these medicines I'm throwing at you left and right. And Dr. Cohen, how did you know? And things were so easy before this all started. And now look what you did. And then Dr. Dalal came on and ruined everything. Actually, there is a method to the madness. Okay. Oh yeah, there's his right. So you're not quite sure what happens at it works. So this is trial and error, right? The cat says, I want to feel a bounce, and knocks over the glass, and then it says, well, maybe that one will. Sometimes we also say, well, looking at who's sitting in front of us, do they also have heart conditions, high cholesterol, diabetes? Have they had cancers or family history of cancers? And that might actually help us choose what medicines to pick as well, too. And perhaps one of the best questions is, well, what does the patient want to do? It's interesting. I'm not going to do this today, but often I'll poll people and I'll say, okay, I'll poll people in the room and I'll say, let's say the same medicine, you could take it any way you want. Would you want to take 1 pill a day? Would you want to give yourself a push button shot like Humira every 2 weeks? Would you want to get an IV? 3 IVs in the first 2 months, and then every 8 weeks you get an IV? Or would you want to start with IV and then move to a shot? And everybody answers differently. So sometimes we can let the patient help decide which medicine they're going to be on, because I think this way also they're part of the discussion, right? Some people just can't remember to take a pill. Some people just won't be able to give themselves a shot. Some people who travel all the time said, I can't go for IVs because I'm halfway across the world all the time too. So we try to personalize the approach. It's called personalized medicine, right? So what we're working on, and this is the research that we and our colleagues around the world are doing, and I mentioned the Research Foundation. Ideally, we would know what's the best medicine to use first. Remember all those ones I just showed you? Maybe through a blood test or a stool test or a saliva test, we would know, well, these are a lot of medicines, but this is the one to go with first. And we're getting there. We would then maybe be able to say, this be from that stool test or saliva test, this would be the best one. Or, well, if you're considering getting pregnant, this would be the best one. And then we like to prove things are working. We can prove it in different ways. So we would have to do, it used to be we'd have to just do a colonoscopy again or a CAT scan, but now we can do a stool test where they just look for inflammation, or we can do an intestinal ultrasound where we just put an ultrasound probe on the belly and see if the medicine's working too. So there are advances in that way. We do lots of clinical trials. We're always looking for people to join clinical trials. Just remember, every medicine that's on the market, patient volunteers took, and they took the drug or fake drug, placebo, and see if they got better, and that's how the medicines make it. So if you are interested in our clinical trials, which is also on our website, we'd be happy to speak to you. So this is a picture of our team before COVID. Our team is actually much bigger than that. We have some team members here tonight, but what we're going to do now is we're going to move to Dr. Dalal. She's going to talk about some common IBD questions, and then we're going to have our panel up and we'll be doing questions and answers. So thank you very much. Thank you.
All right, thank you. So we're going to move into some common IBD questions. I want to leave plenty of time for your questions. We want this to be for you. But first, we're going to start with some things that patients will commonly ask during clinic to sort of kick us off and get us thinking. Okay, so these are some disclosures. Okay, so the first question is, why are more people getting IBD? We hear about it more and more, and we know actually if we look at the numbers around the world that there's been a really rapid rise in the rate of patients getting ulcerative colitis and Crohn's in the past 50 years. That's much quicker than genetics can change. So what could it be? Lots of things have changed in the past 50 years in the way we live. There have been a lot of changes in our diet and preservatives in our food and what we eat and how we eat. There have been antibiotics and a rise in antibiotic use. There's this question of hygiene. Are we exposed to less things in our environment than we used to be? Are there certain infections that we're getting that are triggering things? Or do we just have better ways to find it? Every time you hit an ER, you get a CAT scan, and they find lots of stuff, on the CAT scan. Or we make everyone get a colonoscopy, so we find more things if we look for more things too. So this little picture on the right shows some of the things that people have looked at. They've looked at how you were born. Were you born by C-section or vaginal delivery? Were you breastfed or bottle fed? What runs in your family? What medication? How many ear infections did you have a kid? And how many times did you get antibiotics? What chemicals are in your environment? What food did you eat? All of those things change the bacteria that live in your intestine. There's millions of bacteria that live in your intestine. They're really important to keep you healthy. But they rapidly change in response to all of these things. And we know that ulcerative colitis and Crohn's patients have different bacteria in their intestine. That's probably one of the ways that the diseases get triggered. So what causes IBD? It's a mixture of having a genetic susceptibility, seeing these environmental triggers, and then ultimately an overactive immune response. The genetics in IBD are complex. A lot of you might think, well, there was no one else in our family who ever had this before. Where did it come from? Why did I get it? There's over 200 gene locations that are associated with genetic risk. You can't get a gene test to find out if you're going to get IBD because you might have one of these gene mutations and never get it. So it's just one of the risk factors, but it's not the whole story. The chances, even if you have an identical twin that has the exact same genes as you, the incidence of both twins having ulcerative colitis is really low. It's only 16 to 18.5%. For Crohn's, it's higher, 35 to 58%, but it's definitely not 100%. So it's not all genetics. And the chance of passing on IBD to your children, if you have Crohn's or ulcerative colitis, is actually really low because of this, because the genes are only one piece of the puzzle. So a lot of patients will ask, they'll say, well, I was told after my colonoscopy that I had Crohn's disease or I had ulcerative colitis, but I looked it up, I Googled it, and I don't have any of the symptoms that they're listing on the internet. Was the diagnosis wrong? Is this really what I have? But the symptoms really depend on where your disease is located. Not all patients have diarrhea or weight loss. So just because you don't have those symptoms doesn't mean you don't have IBD or that the diagnosis is wrong. So in ulcerative colitis, your ulcerative colitis can be just at the very bottom of your colon and the rectum. We call that proctitis. It can just be a few centimeters at the bottom. And if that's the case, then you might not have diarrhea at all. You might not actually be able to go to the bathroom. You may need the laxative. You may have constipation and straining. Might be the opposite of what you would think because that part at the very bottom is really swollen and things can't get through there. You might just be passing some blood or mucus. So you may think to yourself, where's all the diarrhea I keep hearing about? If the ulcerative colitis is throughout the whole colon, then those are the patients that are having really frequent diarrhea and urgency. So it really just depends on where the disease is located. For Crohn's disease can affect any part of the GI tract. And the part that it affects is really going to dictate which symptoms you have. Crohn's disease in the esophagus and stomach is not very common. It's more common in those areas in children and less common in adults. If it's in those areas, like the esophagus can be pain with swallowing. In the stomach, it might be something like nausea or abdominal pain. One of the most common locations for Crohn's disease is the very last part of the small intestine called the terminal ileum. And if the Crohn's is in that area, again, you might not have diarrhea, you might have what we call obstructive symptoms or symptoms that things just aren't getting through your intestine because that part at the very end of the small intestine is swollen. Things can't get through there. It's like a partially clogged pipe. So after you eat, you might just feel full a lot more quickly than you used to, or you might feel bloated, or you may have nausea or vomiting or abdominal pain. And those are symptoms that are, in a 18 or 19-year-old that says they have abdominal pain or bloating, a lot of people will say, well, you just ate the wrong food or you did the wrong thing. And they can be really subtle and hard for people to figure out. If the disease is in the colon, then it might be like ulcerative colitis. Those might be the Crohn's patients that have diarrhea. Often Crohn's disease isn't at the very bottom part of the colon, so sometimes there's not blood in the stool. So these conditions can present with a lot of different symptoms, and just because your symptoms are not like everyone else's doesn't mean you don't have the condition. It just maybe you have a different kind than them, and that sometimes helps us decide which medication will work best. So how are we going to know if all these medicines that Dr. Cohen told us about are working? We're going to take them, we're going to go to these infusions, or we're going to take these shots, and how are we going to know that they're doing what they're supposed to do? Well, we're going to check your blood work and see that everything got normal, that you're not anemic anymore, that the marker of inflammation is down, that your nutrition is restored, you're growing and developing as you should. You have an improved quality of life. You can go out and do all the things that you want to do. You're not worried about where the next bathroom is or how you're going to get there or what if you don't get there. You can do whatever you'd like. Your intestine is healed, and we need to check for that and make sure of it. And you're not getting precancerous changes in your intestine or cancer. So we know that even if you're feeling well, it's important to treat these conditions because damage accumulates over time. So this graph for Crohn's disease shows us, you see this line that's sort of going up and down. That's sort of periods of flare and periods of remission. So there's periods where patients have a lot more symptoms and they don't feel well, and there's periods in the middle where things seem quiet. But all along, you see this brown line that's kind of going up and up because over time, inflammation becomes scar tissue. And all these medicines are really good at treating inflammation, but none of them treat scar tissue. So we really want to use the medicines when they're going to work, which is when there's inflammation, but we don't want to wait too long and let all this scar tissue form because at that point, surgery is what treats it. And surgery isn't a failure and it isn't something that we want to avoid at all costs. Sometimes it's the best treatment, but we want to use the medicines when they're going to work, when there's inflammation. So what about ulcerative colitis? Why is remission so important in ulcerative colitis? So you want to prevent things like losing weight, being malnourished, not able to go to work or school or do any of the other things that you'd like to do. You don't want to have bad anemia. We know that having ongoing inflammation in the colon is a risk factor for getting precancerous changes. And we know that controlling the inflammation and healing the colon is the one thing that we can control, that we can actually help affect getting those precancerous changes in cancer. So how do we check for remission? How are we going to know if we got there? So first, we know that changes in your symptoms can happen for many reasons, right? Just because all of a sudden you're going to the bathroom more, it doesn't necessarily mean that you're having a flare-up or that you're doing well, right? Your symptoms can change because you're stressed, because you have a lot going on in life, you got an infection, you have scarring that's affect your intestine, you started a new medicine for maybe something totally unrelated that had a side effect. So we can't necessarily correlate, oh, you're telling me you feel this way and it means this. There's not always a one-to-one relationship between those things. So we really have to look a little bit further to make sure that the intestine is healed. So of course we can do an upper endoscopy or a colonoscopy to make sure that the ulcers, the redness or the swelling that we saw initially are gone. We can do a CAT scan or an MRI, or Dr. Cohen mentioned intestinal ultrasound. That's a good test to see if there's still inflammation in your intestine. We can do a pill camera called a capsule endoscopy. Not everyone can do a pill camera. If you have a narrowing or a stricture, it could get stuck. So it's not for everyone, but in certain patients, it's a good way to find out if there's inflammation. We can do a stool test. We do stool tests sometimes to make sure you don't have an infection because IBD patients often can get an infection because those bacteria in your intestine are not the same ones as in healthy patients and more vulnerable to infection. But you can also do a stool test to look for inflammation. That's called the fecal calprotectin. So all those white blood cells that attack your intestine have this protein called calprotectin in them, and it gets into your stool if there's inflammation. So that's a good way if we're not quite sure, oh, is this really a flare-up or is this, something else going on? We can do that stool test to find out. We also have some blood test markers for inflammation. There's the C-reactive protein. Not every patient's CRP is elevated when they have inflammation. For some patients it is, for some it isn't. So if you're someone whose CRP is elevated when you're in a flare-up, we can follow that. Platelets can be higher when there's inflammation. Your protein levels in your blood can go down. So those are some of the things that we can look at to make sure that the medicines are working as they should. So once you're well, then what? Can you just go off the grid and live your life and never come to see Dr. Cohen or I or our colleagues? Unfortunately, you're kind of stuck with us. You have to keep seeing us to make sure that you stay well and that you stay well on the medications and that we're keeping track of your health maintenance. So it's really important to keep track of your vaccinations, getting the flu vaccine every year, making sure you've had pneumonia vaccination. Dr. Cohen mentioned shingles vaccine, which actually anyone over 19 that's on immunosuppression can get. It's not only for people over 50 anymore. Making sure you're preventing skin cancer. Some of our older oral medications like 6-MP or azathioprine increase the risk of some skin cancers. It's really important to make sure that everyone is using sun protective strategies, seeing a dermatologist if they need to look over all of their skin. Cervical cancer prevention. We know actually that patients with IBD that are on medications that suppress their immune system, that there's higher rates of precancerous changes in the cervix. So unlike the general population that's not on any immunosuppressive medicines, screening should be done more frequently. And then bone health. Patients with IBD often have difficulties with absorbing things like calcium and vitamin D. Unfortunately, a lot of patients have had to take steroids for much too long, and all of those things affect your bones. So even in people that normally wouldn't need a DEXA scan to look at their bone density, to look for osteoporosis, we do this much younger in IBD patients. Colon cancer screening. So this is very important. We know that the risk of colon cancer goes up in people who have more than a third of their colon involved by either ulcerative colitis or Crohn's. And that really starts to go up after you've had the condition for at least 8 years. So after that time, we're doing a colonoscopy every 1 to 3 years because we want to make sure that we catch any precancerous change early and we take it out and it never goes on to become a problem. And this is one of the things that we need a colonoscopy for. We can't use a CAT scan or an MRI or an ultrasound to look for these changes. We need to actually look with the scope and take some samples for it. So it's important to keep track of that and stay on schedule with those. Fertility and pregnancy in IBD, Dr. Cohen touched on this a little bit, but fertility rates are the same in IBD patients as the general population. If you're in remission, that there's no inflammation going on and you haven't had surgery that could cause scarring in the pelvis. Active inflammation can decrease fertility, and it's the greatest risk to a healthy pregnancy. So our biologic medications are safe in pregnancy. They're safe to continue. It's much more risky to have active ongoing inflammation. Baby needs mom to be healthy. There's not enough data for those new oral small molecule medications yet to really recommend them during pregnancy. So in summary, the IBD incidence is increasing, maybe due to environmental exposures that affect microbiome or all those bacteria in the intestines. Your symptoms depend on what type of IBD you have and where it's located. So it's not the same for everyone. And just because, someone else, symptoms don't present that way doesn't mean that your symptoms don't mean that your disease is active. It's very important to enter remission and maintain remission. Even if you're feeling well, it's really important to heal the inflammation and prevent damage from happening. Once you are well, it's really important to keep up with your health maintenance to stay well and make sure that you stay safe on your medications. And IBD patients can have healthy and safe pregnancies when they're in remission. And really, we could extend this to say IBD patients can have healthy and safe lives and do all the things that they want to do, and that it shouldn't be something that holds patients back. They should expect to be well and do all the things that they hope for. So with that, I'm going to end so that we have lots of time for your questions.